Welcome to the Deep Dive. Today we're tackling a topic that is, well, it's absolutely foundational for anyone in surgery. Preoperative care. It's often seen as just, the admin side of the job. But this is really where you save lives, long before a scalpel is even picked up.
It's the entire foundation. If you think about surgery as, say, a major space mission, the preoperative phase isn't just the final checklist. It's the design, the engineering, the crew training, all of it. If you miss a critical system check there, the rocket explodes on the launch pad.
Or fails mid-flight, which is even worse.
Exactly.
That's a powerful way to put it. So we're getting into Chapter 21 from the 28th edition of Baily and Love, Preoperative Care, including the high-risk surgical patient.
A critical chapter.
And for you, our listener, we just want to be really clear about our mission here. This isn't about us reading the textbook to you. I mean, that would be incredibly dry.
And not very efficient. No, our promise is to give you a structured interpretation, a high-value distillation of what's in there. We want to pull out the crucial metrics, the specific thresholds, the why behind the rules. Think of this as a kind of mental framework.
A framework you can use to make your own reading of the chapter more effective.
Precisely. And it can be a quick revision guide when you come back to it later. We're giving you the architecture to hang the details on.
Perfect. So let's start with that central question. Why so much focus on the patient before they even get to the operating room? Isn't the surgery the main event?
The surgery is the main event, but it's also a tremendous physiological insult. We have to see it for what it is. A successful, technically perfect operation still triggers this profound stress response.
A shockwave, you've called it before.
It is. It's a shockwave to the entire system, and it's quantifiable.
How so?
The stress of a major operation causes an immediate and sustained increase in oxygen demand. We're talking up to 40% higher oxygen consumption for days after the surgery.
40%. That's a massive increase for a system that might already be struggling.
It's huge. And if the patient's heart and lungs can't meet that demand, they fall into what we call an oxygen debt. And that leads directly to organ failure.
So pre-op care is essentially preemptive damage control.
That's a great way to put it. This demand spike, it triggers a whole cascade of bad things. You get a huge inflammatory response, cytokine release, massive fluid shifts, and the blood becomes hypercoagulable.
And this all lasts for days.
For days. The entire goal of meticulous preoperative care is to build up the patient's reserves so they can withstand that trauma.
So summary box 21.1 in the chapter, it lays out the ultimate goal. It's not just about ticking boxes.
Not at all. It's comprehensive. First, gather all the relevant info. Then, optimize the patient's existing conditions. Then, choose the safest possible surgical plan.
And you plan for the adverse events you think might happen.
You plan for failure, and you make sure they are hydrated, nourished, and as fit as possible going in. It's about building a personalized safety net for that one individual.
Which brings us right to the mechanics of it, the foundation.
The multidisciplinary team.
Right. Section 1, the MPT approach and patient history. The idea of a single surgeon making all the calls feels, well, pretty outdated now.
It is. The shift to a multidisciplinary team, or MDT, isn't just a nice idea. It's mandatory best practice. Perioperative medicine is its own specialty now.
So who is on this team?
You've got the surgeon, the anesthetist, often a dedicated perioperative physician, specialist nurses, physios, dietitians.
Why is that so essential? Especially for elective planned surgery.
Because optimization is holistic. It's not just about tweaking their blood pressure medication. It's coordinating smoking cessation, structured weight loss, supervised prehabilitation.
So a dietitian's input for a malnourished patient is just as critical as a cardiologist's.
Absolutely, because both directly impact the body's ability to heal. It's all connected.
That makes sense. Okay, let's get into the process of gathering that information. Systematic history taking. The chapter makes a really interesting point about what you document.
Yes, the important negatives from Table 21.1. It's this idea that you must document what isn't there just as carefully as what is.
Why is the absence of something so important to write down?
It does two things. First, it's reassurance. It shows you've checked for a common risk factor and it's not there. Second, it's crucial for surgical planning.
Can you give an example?
Sure. If you're planning a complex operation for, say, adhesions, you must explicitly document the absence of previous major abdominal surgery. If you don't, someone reading the notes later might just assume you forgot to ask.
So it's proactive, but it's also about clear communication for the whole team.
Exactly. So the history has to be broad, but we need to laser focus on the high-yield, life-threatening stuff.
Start with cardiovascular. What are the big red flags?
You're looking for anything that limits the heart's ability to cope with that 40% oxygen demand spike. So valvular disease is a big one. Ischemic heart disease, angina, previous heart attacks, stents.
And peripheral vascular disease.
Don't forget PVD. It's often a mirror for what's happening everywhere else. If their leg arteries are clogged, you have to assume their coronary and cerebral arteries are compromised too.
Okay, moving to respiratory. Beyond the obvious things like COPD and asthma, what's the one condition the chapter really highlights as being frequently missed?
Obstructive sleep apnea, OSA.
Oh.
It's very common, often undiagnosed, and it means the patient has these intermittent drops in their blood oxygen levels all night.
And that's a huge risk factor.
A huge risk factor. Unrecognized OSA is strongly linked to a higher rate of MACE, major adverse cardiovascular events after surgery. If you don't know it's there, you can't plan for it.
I can see why. Your post-op painkiller regimen can easily tip an undiagnosed OSA patient into a respiratory crisis.
Precisely. Then you have the history of previous anesthesia. This is a literal warning from the past.
What are you looking for there?
Any difficult airway society alerts, history of severe post-op nausea, and the genetic things, like suxamethonium apnoea or a family history of malignant hyperpyrexia.
Finding one of those would completely change the plan.
Immediately. A completely different anesthetic pathway.
And finally, social history. Beyond smoking, what's key?
Recreational drugs, heavy alcohol use, for sure, but the one that's often overlooked is functional mobility.
How does that play into, say, an abdominal operation?
It might not seem critical for the operation itself, but it determines everything about their recovery. Their DVT risk, their rehab plan, and crucially, whether they can be safely discharged home.
Okay, let's try to anchor that with a quick check-in question for you listening.
Imagine you've just taken a history. The patient says they have no formal heart or lung disease, but they report severe snoring, waking up tired, and fighting to stay awake during the day.
Which specific condition must you explore immediately, and why is it so high risk? Think about that MCE link we just discussed.
Pause and think if you need to.
The answer, of course, is obstructive sleep apnea. Those classic symptoms must trigger an investigation. Missing it means failing to mitigate a major risk for post-op heart attack or respiratory failure.
Right, so once the history's done, we move on. Section 2, physical assessment. From head to the very high-stakes airway. This is where theory meets physiology.
And the chapter starts with the basics. Dignity, respect, using a chaperone for intimate exams. But let's get into the specific signs we're looking for.
So generally, you're assessing for things like anemia, jaundice, their overall nutritional state. BMI is mandatory. And frailty.
Frailty is a big one.
Huge. It's a critical predictor of their outcome, sometimes even more than their specific diseases.
And then the focused cardiorespiratory exam.
Here, you're actively looking for signs of failure. An elevated JVP, jugular venous pressure, which suggests right heart failure, swelling in the legs, listening for bruits over the major arteries.
And you need to quantify their reserve, not just listen to their chest.
Exactly. Check their oxygen stats at rest, and then check them again after a bit of exertion. Do a peak expiratory flow rate, get some numbers.
We're also looking for abdominal masses, doing a baseline cognitive screen. But the single highest stakes part of this exam has to be the airway assessment.
Non-negotiable. This is life or death stuff. We sometimes call it the anesthetist's crystal ball.
A crystal ball.
Because these simple measurements, they predict the difficulty of 3 critical life-saving maneuvers. Can we use a bag and mask to ventilate them? Can we get a tube in? And if both of those fail, can we get access to the front of their neck?
You're planning for the worst-case scenario before you even start.
You have to.
Okay, let's break down the geometry here. First up is the modified Milan-Potty class.
Right, from table 21.3. It's a visual grading. The anesthetist just asks the patient to open their mouth wide and stick out their tongue without saying, ah.
And grade 1 is a perfect view.
Perfect. You see everything, the pillars, the soft palate, the whole uvula. Grade 4 is the big red flag.
What do you see with the grade 4?
Just the hard palate. The tongue base is so large it's obscuring everything behind it. And that view directly predicts the view you'll get with a laryngoscope.
So a grade 4 means you're almost certainly going to have a difficult intubation.
And you need to have your alternative plan ready to go. Video laryngoscope, fiber optic scope, whatever it may be.
Next are the physical distances. Mouth opening has to be more than 3 centimeters.
Simple mechanics. If the mouth doesn't open wide enough, the blade won't go in.
And then the external neck geometry. 2 key distances. First, thyromental distance.
That's from the notch in the thyroid cartilage, the Adam's apple, down to the tip of the chin. It needs to be more than 6.5 centimeters.
Why that specific number? What does that space tell you?
It's the size of the submandibular space. You need that room to displace the tongue and align the different axes, the oral, pharyngeal, and laryngeal. If that distance is short, you can't get that alignment, and you'll never see the vocal cords.
Okay. And the second distance, thyrosternal.
That should be over 12.5 centimeters. It's about overall neck mobility. Then you check the dynamic movements. Can they push their lower jaw out past their top teeth? And can they extend their head back properly?
And the book is very clear that the risk shoots up when more than one of these is abnormal.
Hugely. You might be able to handle a grade 3 Malampati on its own, but a grade 3 plus limited neck extension from arthritis and a short thyromental distance. You've just gone from a routine airway to a potential crisis.
And you add in other things like poor teeth, a beard that stops a mask seal, previous neck surgery.
All of it. It's a composite picture of risk.
Let's test this right away. A check-in question for you.
Imagine a patient, obese, Malampati grade 4, and a thyromental distance of 5.5 centimeters. First, what do you see in a grade 4 view? Second, what is the mandatory action for the team brief in theater?
The answer to the first part, you can only see the hard palate. And for the second part, with two major risk factors, you must prepare for a can't intubate, can't ventilate scenario.
Which means?
It means your most experienced anesthetist has to be there. A video laryngoscope is the first-line device. And the kit for an emergency front-of-neck access, a cricothyroidotomy kit, is open on the trolley and checked before you start.
Perfect. So, with that assessment done, we move to Section 3, targeted investigations, the pre-flight checklist. The big danger here is just ordering tests out of habit.
That's the core rule, isn't it? We only order a test if the result will actually change management.
Exactly. If it's just interesting but doesn't change the decision to operate, the anesthetic plan, or the post-op care, it's a waste of time and money.
So let's run through the key ones. A full blood count or FBC?
You need that for any major operation, for all elderly patients, and for anyone you suspect might be anemic. You have to have a baseline.
And UNE's urea and electrolytes.
They're needed pretty broadly. Before all major ops, anyone over 65 and anyone with a history of heart, kidney, or endocrine disease.
And if they're on certain drugs.
Yes, things like diuretics or steroids that can mess with their potassium and sodium levels.
For diabetics, an HbA1c is a must if it hasn't been done in the last 3 months.
And there's a specific target. Less than 69 millimoles per mole for elective surgery. If it's much higher than that, the surgery should be delayed to get their sugar control better. Poor control means a much higher risk of infection.
Okay, what about routine clotting screens? I hear a lot of debate about those.
They are not routine. You only order one if the history suggests a problem, a known bleeding disorder, liver disease, or if they're taking anticoagulants.
But the textbook gives a big warning about interpreting them.
A huge warning. Your standard lab tests, your PT and APTT, they cannot reliably measure the effect of the newer anticoagulants, the DOACs.
So a normal result could give you a false sense of security.
Completely. You have to rely on knowing the time since the last dose or use specialized assays.
The ECG has clear criteria, too.
Yes. Everyone over 65 or anyone younger who is symptomatic or has a significant history of heart, kidney, or diabetic disease. You're looking for old heart attacks, signs of strain, or rhythm problems.
And then there's the pregnancy test,
which has to be handled with paramount sensitivity. It's mandatory for all women of childbearing age, but you must have a proper discussion and get explicit consent for the test itself, usually on the day of surgery.
Because a positive result changes everything.
Everything. The consent, the drugs you can use, the timing of the surgery.
What about some of the other tests? Blood gas, cross-match?
A blood gas is vital if you have someone with chronic respiratory problems or sepsis. A cross-match, where you get blood ready from the blood bank, is only needed if you expect to lose more than 500 milliliters of blood.
So you're planning for a transfusion?
You're planning for it, yes.
Let's apply this with a quick case study scenario.
A 70-year-old patient, they're having a minor elective orthopedic procedure, maybe a carpal tunnel release. They feel fine, but they have a history of controlled hypertension and diet-controlled type 2 diabetes.
Okay, so based only on their age and comorbidities, which 2 tests are mandatory, even for this very minor surgery?
Think about the age cutoff and the systemic diseases.
The answer is UNEs and an ECG. The age of 70 automatically triggers both, as do the hypertension and diabetes. It's a perfect example of how the patient's physiology dictates the tests, not the size of the operation.
Exactly. You treat the patient, not the procedure.
Which sets us up perfectly for the next step. Acting on those results, Section 4. optimizing chronic conditions.
This is where the MDT really swings into action. Optimization means getting any severe condition managed to the best possible level by a specialist before surgery.
Let's start with cardiovascular disease management. We need a simple screening tool first.
Our anchor here is the stair test. It's subjective, but it's a great starting point.
So, if a patient can climb one flight of stairs without stopping or getting symptoms like chest pain or breathlessness,
Then they likely have enough cardiac reserve to tolerate most standard surgical stress.
simple but effective. But for someone with known ischemic heart disease, timing is critical. Why do you have to wait 3 to 6 months after a heart attack?
It's pure pathophysiology. In those first few months, the heart muscle is healing, remodeling. The scar is immature and vulnerable. If you put them through a major stressor, then you risk a fatal reinfarction.
You're waiting for the heart to stabilize.
To stabilize and for the scar to mature. And in terms of meds, statins and beta blockers are vital and should be continued. But there's a big exception for certain blood pressure drugs.
ACE inhibitors and ARBs.
Yes. They're usually stopped 24 hours before surgery.
Why those specific ones?
They block the body's natural response to a drop in blood pressure. Under anesthesia, blood vessels dilate, and the body needs to be able to constrict them to compensate. If that mechanism is blocked, you can get catastrophic, hard-to-treat hypotension in theater. You restart them the next day.
And for simple high blood pressure, what's the absolute cutoff?
It has to be below 160/100 before you proceed with an elective case.
What about heart failure? What are the objective markers that make you extremely cautious?
A low ejection fraction, or EF, particularly less than 35%, puts them in the highest risk group. We can also use a blood test, a B-type natriuretic peptide, or BNP.
And that tells you how strained the heart is.
Exactly. It's a great marker for the severity. And don't forget AF. Getting someone out of atrial fibrillation and back into a normal rhythm can boost their cardiac output by up to 15%. A huge gain.
Now for the very complex topic of anticoagulation. Let's start with the old one, warfarin.
Warfarin has to be stopped 5 days before surgery. The goal is to get their INR, which is their clotting ratio, down to 1.5 or less.
And the newer drugs, the DOACs.
They're much shorter acting. You usually only need to stop them 2 or 3 days beforehand, and this is a big but, only if their kidney function is normal. If it's impaired, you need a much longer window.
This brings up the idea of bridging.
A really tricky area. Bridging is when you stop the long-acting drug and temporarily use short-acting heparin injections instead. You only do this if the patient's risk of having a stroke is extremely high.
So you're balancing the risk of a clot against the risk of bleeding.
Precisely. And the trend now is to avoid bridging unless absolutely necessary because of the bleeding risk. There's one major exception, though.
Which is?
Patients with mechanical heart valves. Bridging is mandatory for them, and they can't use the newer factors A inhibitors at all for this.
Okay, and what about a recent stroke?
The first 3 months after a stroke are the highest risk period for another major cardiac or vascular event. Ideally, you want to postpone elective surgery for 9 months.
Let's switch gears to respiratory disease management. We know what defines severe disease. What's the most effective pre-op intervention?
Prehabilitation. Specifically, inspiratory muscle training.
So exercises for the breathing muscles.
Yes, structured exercises that strengthen the diaphragm and other respiratory muscles. This directly translates into better lung function after the operation and, crucially, a lower rate of complications like pneumonia.
And smoking cessation.
The benefits are almost immediate. You reduce the carbon monoxide in their blood, which frees up hemoglobin to carry oxygen, and their sputum clearance improves within weeks.
Okay, let's talk about gastrointestinal and fasting risk. We tell patients not to eat, but fasting for too long is actually bad.
It is. Prolonged fasting is detrimental. It causes dehydration, anxiety, metabolic stress. The rules are precise minimums.
6 hours for solids.
6 for solids and milky drinks. 2 hours for clear fluids water, black tea, clear apple juice. And we should be encouraging patients to drink clear fluids right up until that 2-hour mark.
But some groups are still at high risk for aspiration, even if they follow the rules.
Yes. Patients who are obese, pregnant, have a hiatus hernia, or diabetes. For these groups, we use prophylactic drugs like ranitidine or omeprazole to reduce the acidity of their stomach contents just in case.
And the highest risk GI condition of all, liver disease.
Cirrhosis carries a terrifyingly high mortality rate for major surgery. The key tool here is the MELD score.
The model for end-stage liver disease.
Right. It uses objective lab results, bilirubin, creatinine, INR, to give a numerical score that accurately predicts their mortality risk. It helps you have a very frank discussion about whether the surgery is worth the risk.
And if there are liver diseases from alcohol?
Abstinence is key, but it has to be medically supervised. Sudden alcohol withdrawal can trigger delirium tremens, which is a life-threatening emergency in itself.
Moving on to endocrine, metabolic, and renal care. Let's start with the extremes of weight.
Malnutrition, a BMI under 18.5, is a massive predictor of poor healing. They need at least 2 weeks of targeted nutritional support pre-op.
And morbid obesity.
A BMI over 35. It increases every complication you can think of. If you can't delay for weight loss, you have to be aggressive with your prophylactic measures for things like DVTs and aspiration.
And we come back to severe OSA.
If it's confirmed and you have time, the gold standard is 6 weeks of nightly CPAP use before surgery. It's a huge investment, but it dramatically lowers their risk.
For diabetes, apart from hitting the HbA1c target, what's the key practical point for the day of surgery?
Put them first on the operating list.
To minimize their fasting time.
Exactly, to prevent hypoglycemia. For major surgery, we'll often use a sliding scale insulin infusion, a VR3, to keep tight control.
Let's talk about a risk people might not think about: adrenocortical suppression.
This is for patients on long-term steroids, anyone taking more than 5 milligrams of prednisolone a day or its equivalent.
What happens to them?
The external steroids suppress their body's own ability to produce cortisol, the natural stress hormone.
And during surgery, you need a huge surge of cortisol.
You do. To maintain blood pressure and metabolism, if their system is suppressed, they can't produce that surge, and they can crash into what's called an Addisonian crisis, refractory hypotension. It's fatal.
So they need a stress dose of steroids to cover them.
They do. Perioperative supplementation is essential.
And finally, renal failure.
It's all about preemptive stabilization. You have to treat their acidosis, any calcium issues, and especially high potassium. A potassium over 6 is a major risk for a fatal arrhythmia under anesthetic.
And the chapter makes an interesting point about anemia in these patients.
It does. A new, sudden anemia always needs investigating. But the chronic anemia seen in end-stage renal failure is often well tolerated because their body has adapted over time. You don't just transfuse them unless they're symptomatic or you're expecting major blood loss.
Right, because you risk fluid overload.
Exactly.
Let's finish this section with hematological, neuro, and musculoskeletal issues. Refusal of transfusion.
This is a huge one, moving from the clinical to the ethical and legal. Often for religious reasons, like Jehovah's Witnesses.
The documentation here has to be perfect.
Absolutely meticulous. During consent, you must document exactly which products they refuse, packed cells, plasma, and which devices they might accept, like cell salvage. And you have to confirm if this refusal stands, even if it means they will die.
A very difficult conversation.
Incredibly difficult, and it has to be documented flawlessly.
And what about thrombophilia, an increased tendency to clot?
For inherited conditions like Factor V Leiden, you need a hematologist's input for a tailored plan. For everyone else, we use the standard risk factors to guide prophylaxis: age over 60, high BMI, long surgery, cancer, things like that.
With neurological conditions, the key is to continue most medications.
Yes. You must continue anti-Parkinson's drugs and anticonvulsants to keep them stable and help with early mobilization. But some psych meds are tricky. Lithium is usually stopped 24 hours before. And MAOIs are a whole different ballgame. They need weeks of tapering under psychiatric supervision.
And finally, the hidden danger in rheumatoid arthritis.
CRA. This is a unique and very high-stakes risk. It's instability of the cervical spine.
At the very top of the neck.
Exactly, at the atlanto-dens interval. Severe RA can erode the ligaments there. And when the neck is moved for intubation, the spine can slip, causing a catastrophic spinal cord injury.
So what do you do?
In symptomatic patients, you need pre-op flexion extension x-rays of their neck to check for that instability.
The level of detail needed for optimization is just staggering.
It confirms the premise. This is the foundation.
Okay, let's move into Section 5, quantifying risk and predicting outcomes. After gathering all this data, we try to put a number on the danger.
And it's important to say that overall, the system is working. Despite patients being older and sicker, mortality has plummeted over the last 50 years.
But the data also shows what the chapter calls the high-risk paradox.
Yes. This is a really key insight. It turns out that less than 15% of surgical procedures account for over 80% of all perioperative deaths.
So if we can identify and focus on that 15%, we can make the biggest impact.
That's the idea. And we define high risk as a predicted mortality of 5% or more.
Let's just remind ourselves of the physiological trigger here.
It's that oxygen debt. Oxygen consumption jumps from about 110 to 170 milliliters per minute squared. If you can't meet that demand, your organs become ischemic. Gut, heart, brain.
So how do we objectively measure a patient's capacity to meet that demand?
We start with functional fitness assessment using MET-Ts, metabolic equivalent tasks.
1 mK is just your oxygen use at rest.
Right. And the general benchmark for low-risk surgery is being able to achieve at least 4 METs. That's roughly equivalent to climbing 2 flights of stairs.
But that's subjective. Patients might overestimate their fitness.
They do, which is why, for high-risk patients and high-risk surgery, we need the gold standard.
Cardiopulmonary exercise testing, or CPT.
The ultimate objective measure. The patient is on an exercise bike. We're measuring their gas exchange breath by breath, and we're looking for one key metric, the anaerobic threshold, or AT.
Let's use an analogy to explain the AT.
Okay. Think of your body as a car engine. You can cruise along at 3,000 RPM all day. That's efficient aerobic metabolism. The anaerobic threshold is when you floor it and the engine screams into the red line.
You can't sustain that.
You can't. You're producing waste products faster than you can clear them. In the body, that waste product is lactic acid.
And the CPE test finds that exact point, the red line.
It finds the inflection point where CO2 production suddenly rises out of proportion to oxygen consumption, and it gives us hard numbers.
2 key thresholds.
An AT of less than 11 ll-kg-min or a peak oxygen consumption of less than 15 are both associated with much higher morbidity and mortality.
But the great thing about CPET is that a bad result isn't a final sentence.
Not at all. It's a target for intervention. A supervised prehabilitation program over 4 to 6 weeks can significantly improve a patient's AT. You can literally turn a high-risk patient into a lower-risk one.
Okay, let's look at the surgical risk scores. The workhorse is still the ASA score.
It is. It's used everywhere because it's so quick, but we have to admit its main weakness is subjectivity. One person's severe systemic disease might be another's mild.
But even with that subjectivity, the numbers show it's powerfully predictive.
Incredibly. An ASA grade 1, a healthy patient, has a 0.1% mortality. Grade 2 is 0.2%. But then you jump. ASA grade 3rd, severe disease with functional limits, is 3.5%.
And grade V, a moribund patient, is basically a 93% chance of death.
So it works. A more objective score, though, is the Revised Cardiac Risk Index, the RCRI.
And that's focused purely on cardiac risk.
Purely cardiac. It uses 6 objective factors: ischemic heart disease, heart failure, stroke history, diabetes on insulin, renal failure, and whether it's a high-risk type of surgery. It gives you a clear numerical risk percentage.
I want to spend a moment on what you call the adjustment factor. This is a really fascinating concept in the chapter.
It's a critical insight. If you just look at raw, unadjusted mortality rates, vascular surgery looks like the riskiest procedure of all. Nearly 6% mortality.
But then the data is adjusted for the patient population. What happens?
When you factor in that vascular patients are, by definition, very sick, they have severe atherosclerosis, they're often diabetic, heavy smokers, the risk of the operation itself changes. Vascular surgery drops to 5th place.
And what jumps to number 1?
Thoracic surgery. This tells us that for vascular surgery, the patient's underlying health is the main driver of risk. For thoracic surgery, the sheer physiological trauma of the operation is the main driver, even in a fit patient.
That's a huge shift in perspective.
Yeah.
Why does it matter?
It changes how you allocate resources. It tells you that optimizing the patient's medical condition is paramount for vascular cases, but for thoracic cases, you need to focus on specialized post-operative critical care to manage the surgical trauma itself.
Because risk is an interaction between the patient and the procedure.
It's an interaction. Exactly.
Let's do our final check-in question for this section on the ASA score.
Okay. A patient is ASA grade 3rd. What is the approximate 30-day mortality for that grade? And why should you use that number with caution when talking to the patient?
Remember the score's main limitation.
The quantitative mortality is about 3.5%. The caution is because the ASA score tells you about the patient's systemic disease, but it does not factor in the magnitude of the planned surgery.
So an ASA 3rd patient having minor surgery has a much lower risk than an ASA 3rd patient having a massive cancer operation.
Exactly. The 3.5% is just an average across all procedures. It's a starting point, not the final word.
Now that we've quantified the risk, we move to Section 6, Preoperative Strategy and High-Risk Management. How does this risk score influence the actual plan?
It determines choosing the right operation. You have to tailor the approach. For a patient with severe lung disease, for example, a laparoscopic approach is often much better because it avoids a big incision that would impair their breathing.
But the chapter warns that minimally invasive doesn't always mean minimally stressful.
Absolutely not. Think about a robotic prostatectomy. It's keyhole, but the patient is in a steep head-down position for hours with their abdomen inflated with CO2.
Which puts a huge strain on the heart.
A huge strain. It can cause myocardial ischemia, increased pressure in the brain. For a high-risk cardiac patient, that minimally invasive approach could be far more dangerous than an open one.
So you're balancing the risks and benefits for that specific patient.
Always. The next key strategy is ensuring you have the role of critical care sorted, the safety net.
And the reports show that most post-op deaths actually happen late.
Yes, 5 or more days after surgery. This is when the complications like heart attacks, kidney failure, and sepsis really manifest.
And the mortality from those complications is staggering.
Postoperative respiratory failure has a mortality of 27 to 40%. That's why you need that high level of support ready.
But there's a documented gap. The highest risk patients often don't get to critical care.
The numbers are stark. That high-risk group makes up 80% of the deaths, but often only a small fraction of them are admitted to critical care preemptively.
So the recommendation is now clear.
If the predicted mortality is over 5%, which is roughly an ASA third patient having a major op, they should be automatically considered for a critical care bed.
And for those on the wards, we have Critical Care Without Walls.
The outreach teams. They use early warning scores to spot subtle signs of deterioration on the wards, a slightly increased breathing rate, a small drop in blood pressure, and they intervene before the patient crashes.
Then there's the simple logistics of organizing the theater list.
It's crucial for safety. Patients who are vulnerable to starvation kids and diabetics have to be first on the list.
And you can be strategic.
Very. You might do a short, straightforward case first while you're waiting for the final cross-match results or the critical care bed confirmation for your second, much higher risk case.
Finally, what about emergency surgery? The principles are the same, but the timeline is compressed.
The principles are identical. You just have hours or even minutes to do your assessment and optimization. We use the NCEPO classification to grade the urgency from immediate, meaning minutes, to elective.
And sometimes you have to operate while you're still optimizing.
You do. A septic patient might need fluids, antibiotics, and even a short period in critical care to correct life-threateningly high potassium before you can safely take them to theater for the life-saving operation. You stabilize what you can as fast as you can.
This has been an incredible deep dive. It really shows that pre-op care isn't just the overture, it's the entire blueprint for success. We've gone from the systematic history to the predictions of the airway crystal ball, through the objective fitness measures of the stair test and CPET, and into quantifying risk with scores like ASA and MELAN.
And the core takeaway, I think, is that this careful, collaborative preparation is the surgeon's most powerful weapon against the inevitable physiological stress of the operation. You're treating a complex human system, and you have to maximize its resilience before you introduce trauma.
We really hope this framework helps you turn the dense information in Chapter 21 into structured, memorable knowledge.
We do.
And before we close, let's leave you with a final thought to consider. It builds on this tension between objective fitness and subjective risk.
We've said the ASA score, a subjective measure, is a strong predictor of mortality, but we also have these high-tech objective measures like CPET that can tell us a patient's true functional capacity.
Right.
So here's the ethical dilemma. What do you do when a patient has a very high ASA scores, say grade, but their CPET shows they are actually exceptionally fit with high meat Ts, and they need a resource-intensive elective procedure?
Should that objective measure of fitness always override the generalized risk score when you're deciding who gets a limited resource, like a critical care bed?
It's a real tension. Do you prioritize the fit patient with bad disease markers or the unfit patient with slightly better ones? It's a question our health systems are grappling with right now, something to research further.